Children are smart and savvy, and they're also kind and loving and protective of their parents the same way their parents are protective of them. We often see parents that, coming from a place of love, say, I don't want my child to know what's happening to them. I don't want them to know they're dying. I don't want to burden them with that. And then we have a child that's saying, I feel like this isn't going well, and I'm worried I'm dying, but nobody's really told me. And my parents don't seem to want to talk with me about it, and the other doctors don't seem to want to talk to me about it, so I'm just going to keep it inside and not talk about it. And you have these two groups sort of trying to protect each other by pretending like what's happening is not happening. And oftentimes it feels our work when we're going into a room where the family is sad on one side and the child is sad in their hospital bed, and both of them are sad alone, trying to give them the words to be sad together and talk about it, because they're each other's most important people. Not only is it not damaging for children of a certain age to be able to talk about what's happening to them, but it's empowering, and it's actually helps some of the symptoms and helps some of the suffering and helps the challenge to just give them the voice to talk about it in whatever way is both kind of developmentally appropriate and feels right for them and their family.
Today's guest is Dr. Jared Rubenstein, a pediatric palliative care physician who has spent his career helping children and families through some of life's hardest challenges. He has served as a program director for Baylor College of Medicine's Pediatric Hospice and Palliative Medicine Fellowship at Texas Children's Hospital in Houston, and he recently moved to Vancouver, Canada, where he has become head and medical director of the Division of Palliative Medicine at BC Children's Hospital and the medical director of Canuck Place Children's Hospice. He's become a respected educator, speaker, and creator of online videos that help people better understand serious illness, communication, and compassionate care. With that, here's my conversation with Dr. Jared Rubenstein. Palliative care for adults is hard enough, right? You chose to do it for kids. Some would say that's the hardest of the hard. Some people may think it would be torture to do something like that day in and day out. Why did you choose this career as your life's work?
Yeah, well, thanks for asking. It's a good question, and it's not one I sort of planned from the beginning necessarily. I really first learned about palliative care before I knew it was called palliative care at my childhood dinner table. So growing up, my dad was a adult pulmonary and critical care doctor, and my mom was a social worker. And it often felt like our dinner table conversations were like little team meetings, and my dad would talk about his work, but not so much the heroics of intensive care medicine, but he would talk about the hard conversations and the being with people and supporting patients and their families at the end of life. And my mom would talk about going to funerals with him and the connections he formed with people and their families. And it always just stuck out in my mind as really sort of beautiful and important, worthwhile work. But I was scared of hospitals as a kid, and so never thought I could be a doctor and do it myself because I never wanted to be in a hospital. And then in college, I kind of found my way back to medicine and ended up going to medical school, and realized when I got there and enough time had gone by that now there was a whole field called palliative care that was really a lot of the stuff that my dad had always talked about. And I did elective in palliative care and just loved it and felt like, yeah, it can be emotionally hard, but it's also an opportunity to just be with people at the hardest times. And that's just such an honor and a privilege so that they don't have to go through it alone. And then later on did my pediatrics training and thought maybe there's pediatric palliative care. And there wasn't really where I was in training at the time, but was able to do some visiting rotations at other hospitals that had programs and just loved it. And now it's been like about 12 years in the field, and I can't imagine doing anything else. It absolutely can be hard, and it is hard. And we don't do it alone. We do it as a team. We have great interprofessional work. So when I'm seeing patients and their families, it's often with their other doctors or nurses or a social worker or a spiritual care provider, with the goal of really being there for that patient and family as a whole unit and kind of thinking about them as a whole. And there's the added benefit of when we walk out of the room, we were all in it together and can debrief and kind of process together. And I think a lot of times people assume when they hear about this work and they come to meet our team that we're going to be these kind of broken shells of people because of what we see every day. And they end up really enjoying their time with us. And we've had medical residents or medical students that come and say, this month felt healing to me that I spent with you and your team. And they're right. I think because we see harder than average things, we sort of normalize that we should talk about it and we develop kind of team coping strategies. And we all have our own wellness and self-care stuff we do, but also things together that we talk about it, that it's hard. We name it. We create space for each other to kind of process and share together. And I think that helps with it when it is hard. Some days it's not hard at all. Some days we are just being with people and getting to know them and their families and meeting these wonderful children and their parents and getting to talk about what's most important to them and what good days like and what makes life worth living. And I think days like that are beautiful and I'm grateful for the ones that don't feel as hard. And I'm equally grateful for the ones that do feel hard because I think in a lot of ways, in our world of toxic positivity where everyone says, oh, at least it's not that, or somebody's in a better place, or all of these things that we know aren't really helpful to people, creating space for people to be with their hard feelings and let them know that they're valid and okay and that we want to hear about them, I think is precious and really worthwhile. And I love being able to do that for people.
I think that's so important for adults too, right? Adult hospice at least, and then especially for kids because you're also dealing with the family members, right? Not just them as a patient, but like the entire family. Um,
Yeah.
was there a moment that you recall that that made you decide this? Did you maybe have an experience? Maybe you had something personally that really just turned on the light bulb?
Yeah, I think for me, a lot of it, and a lot of us, I think, in sort of my generation of palliative care clinicians, it came from being in situations where you didn't have access to good palliative care and seeing what it was like as a pediatrician when children were going through very rough illnesses, rough treatment courses that weren't being supported in the full way they deserve and weren't getting expert symptom management with symptoms from their disease or symptoms from treatment where the families weren't getting kind of robust wraparound support. And when families were being asked to make impossibly difficult life or death choices with huge implications for themselves or their family or their children and being put in positions to do it alone without support of people that really expertly knew how to guide people in making the right choices for themselves. And so I think for me, a lot of initially what drew me to palliative care was knowing about it and seeing what happens when you don't have it. And then as I was able to get further along in my training and go to programs where there was robust palliative care and pursue my own training in palliative care, combining it with the beauty and power and impactfulness of seeing how it's different when there is really wonderful palliative care support. Kind of the combination of those two things is what brought me to the work, and it's what keeps me in the work every day because I still think we're in a world where not enough people do have access to robust palliative care support, and part of my passion and my work is working to change that.
Yeah, I think you have some videos on YouTube where you're trying to educate the medical community, perhaps, maybe also families as to what exactly palliative care is and not to be afraid of it.
Yeah, absolutely. My YouTube channel started very much by accident, where I made one video after a frustrating exchange where I felt like the healthcare worker I talked to didn't understand and had a lot of biases and stigma associated with palliative care. And I went back to my office and made what had became the fire department video, and I thought that was just gonna be one video, and now it's been about 5 or 6 years and 70 videos later, and I think it's largely, but not only for a healthcare audience. I see a lot of people doing a lot of really good work about the public conversation around palliative care and public perceptions and normalizing it and creating space for those conversations. And so I don't focus on that as much because I think so much good work is being done there. I see less sort of focusing on the healthcare community to work on the myths and misconceptions around palliative care. And so that's sort of where I've planted my flag and where I work in it. And the YouTube channels really just they're usually 1 to 2 minute animated videos that are often satirical, often sort of laden with metaphors to really help people wrap their head around it in a kind of disarming way. And as a kid that grew up watching The Simpsons and South Park and realizing that, you know, animated like cartoons can be fun and funny, they also can be disarming and open the door to really important conversations and have really tried to lean into that model.
Palliative care may be new to a lot of people. A lot of people obviously don't have experience with it. What is it that you actually do? Right. So you're a physician, you work in a hospital, palliative care team. What is it that you and your team actually does?
Yeah, and so now in my new role that I've started over the last couple of months, I work in a hospital and I also work as part of a team at a hospice house that is able to take care of people in the house, but also have community outreach throughout our province. And for pediatric palliative care, I would say, our goal is we want to meet all children and families who are dealing with a serious illness and knowing that serious illnesses can come with physical symptoms and challenges. There can be emotional challenges. There can be spiritual challenges. Our goal is to be a wraparound support really for all of it. And we can help with pain or other challenging symptoms that come up. We can help be a sounding board for any of those big decisions that come up. We can help really be a support for the family, like you mentioned earlier, that as much as the child's going through, there's often some support for that. There's often a lot less support for the family. And so being there to kind of be a check-in space and a support for the family as well, always kind of with the looking at the lens of our main goal is we want to minimize suffering and maximize quality of life. And so we meet children sometimes from the point of diagnosis and can start working on all those things from the beginning of a serious or life threatening illness. And sometimes we meet them later in the illness closer to the end of life. And our team's role there becomes really providing expert medical care and social and spiritual care so that the child and their family get the end of their life that they deserve with a focus on maximizing quality of life and minimizing suffering. But our hope is really to be able to interact all across the spectrum of illness from diagnosis through the end and then supporting the family and bereavement as well.
Kind of patients are we talking about? What kind of children? What are some of the diseases that you take care of or help take care of?
Good question. For us in pediatric palliative care, I think a lot of people automatically think cancer, and that is a portion of our patient population. It ends up being about a third of the children we take care of are children who have cancer. Another third about ends up being children with severe neurologic impairment and medical complexity. So children that, whether it's from a genetic or metabolic condition or uh, early brain injury or the effects from being born very premature and whose brains never have the chance to fully develop and have severe neurologic impairment, often not able to communicate verbally, but can very much communicate in other ways. Maybe not able to walk or talk or feed themselves and are fully dependent for care, helping those children be able to live life to the fullest as well and help them navigate a very challenging medical system that's not necessarily made for a lot of the challenges they have. And then the last third is children with other kind of serious illnesses, whether it's congenital heart disease or acquired heart disease, lung disease, things like cystic fibrosis, anything that causes either significant challenge or disability or has a profound effect on their daily life or something that's likely to shorten their life. Really, anyone with that kind of falls into that third category that we want to be able to be there for.
Yeah, I think the spectrum's pretty wide with palliative care. A lot of people, and we'll talk about it later, but in hospice, it's when in adults at least, when you have, I think, 6 months or less to live, palliative care, you may be with some of these children for years. right? It's not just, um, months. Mm.
Absolutely. And I think there in the States, hospice, because of the American healthcare system, has become sort of part a group of care, part a philosophy of care, part an insurance benefit. And it's all those things that are kind of intertwined that leads to this certification of a 6-month life expectancy to be able to access the services. Through the Affordable Care Act in 2009, one of the great downstream effects of that was the concurrent care clause as part of the Affordable Care Act that says children who are 21 or under and on public insurance are able to access the benefits of hospice without having to give up other medical care. And so because for kids, that prognosis piece can be so much more uncertain because children's illnesses are a little harder to predict and a little less cookie cutter than many adult illnesses. And so the ability for children to be able to access curative care and hospice at the same time was really practice changing for us. And I think life changing for a lot of our patients because in the adult model, you need both that 6-month prognosis and you need to agree that you're not going to go back to the hospital. You're not going to pursue disease directed treatments. You're really just going to focus on symptomatic and quality of life care. And then in Canada is another layer of a different system that I'm after 2 months here, I'm really just starting to wrap my head around. But because it's a publicly funded healthcare system with a single payer where it can really think expansively about just how do we take care of all of the people living in our province. And so there's not rules and regulations in the same way that you don't have to check as many boxes. It's really about getting kids plugged into our program who have a serious illness and need the support, and then making sure that they can get kind of right-sized care to match what their needs are.
What so trying to understand the work a little bit more, what is the difference between, someone listening may have heard of both hospice and palliative care. What's the difference between those 2 subjects?
Yeah, and I'll speak some in the US model because I think that's still sort of honestly the first place my mind goes because it's the system I've known my whole career until recently. But there's similarities here where, palliative care is kind of the umbrella. Palliative care is all the things I talked about before. It's, how you provide that great person-centered, personalized support for anyone living with a serious illness and their family at any point in the illness. And then hospice is really how you further specialize that care and kind of base it around care, often at home, but not necessarily at home, for people who are in the last stage of their life. And so I think of palliative care as kind of the big umbrella that does these things. And then hospice is a team that can go to your house and take care of you um, alongside your other caregivers if you're near this end stage of your life and ready to make trade-offs about things like going back to the hospital.
Yeah, I was trying to come up with an analogy myself, and yeah, that's perfect. I kinda, thought of an idea. I was like, it's like a pizza is palliative care and hospice is a slice, right? So
Absolutely. Yeah.
yeah, so
I think that's a
hospice
great,
yeah,
yeah. And as a big fan of pizza, I very much support
you
that
support that
analogy.
the analogy. Um, now, what's the difference between pediatric and adult palliative care? Is there a big difference? What are the differences?
In theory, there shouldn't be a lot of differences. In practicality, there end up being a lot more because one, I mean, emotionally, there's a sense of something being wrong with the natural order. Like children aren't supposed to have serious illnesses. Children aren't supposed to die. And so I think there's that sort of intellectual and emotional barrier for people to even think about pediatric palliative care because it means that they have to think about that some children don't survive till adulthood and that some children have challenges nobody should have to think about. Also, because it ends up being a smaller population of people who need pediatric palliative care than need adult palliative care, oftentimes pediatric programs are able to do more and are able to move more upstream and sort of think more comprehensively and not just be the end of life care team. I think a lot of adult palliative care models also don't want to be the end of life team only, but because of resource limitations or practice limitations or just the structure of our healthcare systems, there's so much need for expert care right at the end of life that is often all they're able to do. But in terms of the philosophy of it, I think it's really not that different between pediatrics and adult palliative care. It's all about meeting people who are dealing with any kind of serious illness, ideally at any point in the illness, and providing that comprehensive supportive care.
Yeah. Um, I actually I did a year of volunteering at hospice, adult hospice.
Oh, wow.
Yeah, this was years back, and it was a very moving experience for me to sit with dying adults. There were no children there, but the people that worked there, they almost had a holiness about them. They had this they could almost see right through you. They truly cared about the patients, the people they were caring for, and you could feel it. That was a very moving experience for me, and I would talk to these people, and a lot of them would say that they're not afraid of death, or they're less afraid of death than probably the average person because 'cause they're right there and they see it. So, I've always found hospice ever since then to be such a beautiful thing, and I took a little bit away from that experience that I still carry with me, today. So,
Thank you so much for sharing that. There's a lot in that story that I want to talk about. I think one is that, at my hospice I work at now at Canuck Place Children's Hospice, the volunteers are such a robust part of the team because there's a lot of work to be done in hospice, and we are always grateful for our volunteer community that come and show up and do all kinds of different things. We have volunteers that sit with patients and families and just be a supportive presence. We have volunteers that can help out with siblings when if their sibling is the one who's a patient, but they want to be there at the hospice and need kind of care and support in order to be there and not too much in the way. And they have understandably high needs. We have volunteers that talk to the families and support them. We have volunteers that help with landscaping and facilities and maintenance. There's just volunteers that are so generous with their time and really allow us to do the work we can do with the generosity of their time and diverse skill sets. I think it always sort of makes me pause a minute when people describe our work in using words like holy or magic or something that it's on the one hand very flattering that like I think my colleagues in this work are the greatest healthcare professionals I've ever known. Like I'm totally enamored with them and their work and everything they do. And there's always a little part of me that worries that when something is holy or something's magic, it also is distancing and it's something that's not available to everyone or that like you have to be a certain special, like you have to have a certain specialness or special magic to be able to do this work. And as someone that's been teaching palliative care for the last 12 years, I also want everyone to know that these are our professional skills that can be taught and learned and that I think for anyone that wants to, they're there, whether you want to do all the training to become a palliative care specialist or whether you want to do some training to just to have better skill sets around this in your own work and life. That I think being able to be present and talk with people about hard things, I think is a universal life skill that I wish more people had. I think when we think about communities of support, like no matter how good a team I ever have, our patients and their families are spending most of their time out in the world. And we hear over and over how hard it is that they don't feel seen or they don't feel supported or their experience feels minimized or they become pariahs because nobody wants to talk to them about the hard things they're going through. And my dream, and I think a lot of people's dream that do this work is, yes, we want to do the best work we can in the moment for the people in front of us. And we want to change the narrative and conversation and work towards a more grief literate society and a more death literate society so that the communities that we're all part of know how to support us in a way that I think people used to thousands of years ago. And now with a lot of modern medicine and the distancing of of sickness from home into facilities and hospitals, I think we've lost a lot of.
Yeah, as medicine has evolved, I remember cancers 20 years ago that they were basically 100% mortality, and I think some of the rates are down to like 20 or 30%. So it's uh it's almost like as medicine gets better, there's almost less. I don't know if it's less tolerance for death, or we run the race longer before saying, "Okay, it's not gonna get better." Have you had any of those experiences?
All of them. Yeah, I think that's a really good way of putting it. You're right. I think medicine and cures and speak specifically about cancer, absolutely. And even more so in the pediatric world, there are cancers now that have an upwards of 90% cure rate through the ingenuity and science and modern healthcare that's brought us there. And that's amazing. And we should absolutely celebrate that. And to your point, I think it when we all spend less time taking care of people at the end of life, because more people are not getting there as early, we lose some confidence and competence in our ability to support them in that way. And I think all our successes over the last decades can create a feeling of invulnerability and a feeling of failure that, if you medicine has never been able to cure everyone. But as we've gotten closer and closer to that, the people that we can't cure, not only is it sad, but I think also confronts people with feelings of failure that for some that like it's not supposed to happen and that nobody's supposed to die. And I think that does make it a lot harder to have these conversations and to talk about it when you're layering in our own cultural discomfort about it, compounded with healthcare workers' feelings of failure and families' feelings of failure that it's not supposed to happen or that they couldn't protect their loved one from this. And there was a time in the not too distant past where there was, I think, a more general understanding that not everything can be prevented and not everybody can be saved and cured. And there used to be, I think, more facility and comfort and competence in caring for those people that I think has absolutely been lost over time outside of some very sort of niche communities or specialties where that's the whole focus.
What are some misconceptions people have about palliative care?
This is one of my favorite questions because there's a lot. Some is what we've been talking about already, that it's not needed because we can make most people better, or that um, anyone can do it because it's just being a nice person, or knowing how to talk to someone, or giving them pain medicine, and the field has such a robust evidence base and variety of expertise that I think it's sort of like saying for anything else, like, "Oh, I read a book about hearts once, so I'm a cardiologist," or, um, "I think a lot about breathing, so I can be a lung doctor." Like, it's its own full specialty, whether you're coming at it from a physician lens, a nursing lens, a social worker lens, that there's unique expertise that does not exist in people even who have better than average comfort and competence with these skills. And so I think that's one, is that sort of anyone can do it if you're just nice. And another one is that there's one of the most significant ones that I think affects our work is this narrative that people are scared of palliative care. And we hear all the time, people are scared of palliative care. People are scared of palliative care. Or another doctor will tell me, "Oh, I wanted to bring you and your team in, but like, you know how scary it is. So I don't want to take away hope from the family. So I'm not going to invite you to meet them now." And the data out there is pretty robust and pretty clear that most people are actually not scared of palliative care. Most people don't know about it. And in study after study, the percentage always ends up being around 70% of people that don't really know what palliative care is. And I would submit that you can't be scared of something that you've never heard of before. You're neutral about it and more of a blank slate. And what we know from our own anecdotal experience of doing this work and from the literature that's out there is that people who have heard of it often have a positive perception. People who haven't heard of it if you tell them what it is in a real sort of complete way, also have a positive perception of it. And even when people get told, actually, part of their work is taking care of people at the end of their life, if it's described in an appropriate way, even that doesn't necessarily scare people off. And so these groups have been studied, if you drill down on the populations in these perception studies about um, where do misconceptions or negative biases about palliative care from, they're pretty consistent that they come from healthcare workers. That yes, there's absolutely a population of people that says, I know what palliative care is. That's hospice, and my grandpa had hospice, and they came to our house and gave him a bunch of morphine, and he died, and that's palliative care. So we don't want that. Like, that is people's lived, perceived experience, and I don't want to minimize that at all. But that is way less common than the people who say, we didn't know what palliative care is, but my doctor said, I know palliative care is really scary, but don't be scared. We're going to call them and it'll be okay. And the people say, I wasn't scared before, but nothing makes me more scared than being told not to be scared of something, or being associated with the feelings of failure we were talking about earlier. People say, I'm sorry, there's nothing else we can do for you. So here's the palliative care team. And I think we don't frame anything else like that. We say, um, I'm so sorry. Unfortunately, it looks like you have cancer. I want to let you know we have a world class oncology team here, and we're going to get you the next appointment with them to make sure that you get the best cancer care. And I think there's no reason we shouldn't frame palliative care the same way, that we're not the problem. We're not the bad thing. The bad thing's already happened. And we are a world class team of people that can help people go through hard things with less suffering and better quality of life. And so to me, it's only a value add. And I think a lot of my work talking with other healthcare workers is trying to sort of gently, or sometimes less gently, help them through their own biases and misconceptions so that their patients have access to the great care that teams like mine provide.
I think that this is just my thoughts, that when someone when your physician, let's say they're taking care of you and the child isn't getting better or the patient's not getting better, and they say, "Well, let's bring the palliative care team on." Really, it's the talk of death, right? The discussion of this may not work. The path we're going down doesn't look like it's gonna lead to a cure. And that and you said it perfectly, right? But the fear that people have is actually having that discussion, right? So my dad is you're telling me that he's not gonna get better? Is that why the palliative care team, so you're telling me he's gonna die? And they ask those questions to the physician initially, and it's not, I don't think it's necessarily the palliative care team that's seen as being bad. It's that discussion that you all have that needs to be had, right? I think that's the real fear in, yeah, in that, so
Yeah, I think that's absolutely true. I mean, we ask people to talk about things that are really hard to talk about. And I think also in that example, in bringing in the palliative care team at the same point where you're telling, like, if we're being brought in as a way to kind of sidestep and dance around the we can't cure this illness, to me, that's a problem on a lot of levels. Like, I think we shouldn't be a substitute for that. I think people should be told clearly and compassionately what's happening to them, including when they get to the point where a cure is not possible. And if our teams are being brought in appropriately early, we can be brought in with language like, "Hey, this disease and treatment seem like they're taking a really big toll of you on you. While my team is working on figuring out how we can cure this, I'm going to bring in this other team that's going to help you with the symptoms and the suffering that are part of this disease and treatment." And then our teams can be helpful at that stage, and we'll already know them and have a established relationship if it gets to the point where the disease can't be cured.
so you've spent countless hours, right? You and your team, you specifically, with children who are dying, right? Or have like a chronic illness that will ultimately lead to their death. Um, What do people need to know about, because it's not, we all die, right? Adults die. Of course, kids die, but all adults die. Not every child dies. You have an experience that most people don't. So, what do we need to know? What have you learned about dying children?
I think what's usually surprising to people is that dying children actually want a lot of the same things that dying adults want. They want to feel like they're going to have a legacy. They want to talk about that it's hard and talk about their feelings around dying. They want adults to be, in most cases, open and honest with them about what their body's going through because they can feel it. They know they're not doing well. They know they're having more pain. They know they're spending more time in the hospital. They know they haven't been home in a really long time. They know that the adults that come in the room look sad and don't talk to them about why. Kids are smarter, I think, than they're often given credit for, and more savvy and more perceptive. And so I think kids, especially adolescents, want a lot of the same things that anyone wants in those situations. They want their dignity. They want to be talked to like a person. They want to have sort of agency in what's happening to their body. And I think one thing that we've seen from little kids, but specifically adolescents, is they have all these unrealized dreams in a way that somebody who's much older may not. And that I think sometimes people are worried about opening that conversation because it'll make them sad, but nothing can make them sadder than they already are. And oftentimes giving voice to it and being able to talk through those unrealized dreams and being able to talk through those hopes can be, one, empowering because sometimes some of them actually can be realized if we know about them early enough. And two, even if they can't, I think there's still a power in the agency of letting someone talk about their potential future that isn't going to be possible anymore, even knowing it's not going to be possible anymore. And I think, what we see a lot in our patients is that there's a child in a family, say in the hospital, and the child won't be able to survive. And the medical teams know it, the parents know it, the child probably knows it, but we don't know that for sure because nobody's yet really given them space to talk about it. But they know something bad is happening to them. And children are smart and savvy, and they're also kind and loving and protective of their parents the same way their parents are protective of them. And so we often see parents that, coming from a place of love, say, I don't want my child to know what's happening to them. I don't want them to know they're dying. I don't want to burden them with that. And then we have a child that's saying, I feel like this isn't going well. And I'm worried I'm dying, but nobody's really told me. And my parents don't seem to want to talk with me about it. And the other doctors don't seem to want to talk to me about it. So I'm just going to keep it inside and not talk about it. And you have these two groups sort of trying to protect each other by pretending like what's happening is not happening. And the term for it in the literature is mutual pretense. I think it's Myra Bluebond-Langner with in her book The Private Worlds of Dying Children, I believe, coined that term, that both the child and the family are pretending to protect the other one. And oftentimes it feels our work when we're going into a room where the family is sad on one side and the child is sad in their hospital bed and both of them are sad alone, trying to give them the words to be sad together and talk about it, because those are they're each other's most important people. And it's hard to not be able to talk about it. And over, I'm struck by just how, not only is it not damaging for children of a certain age to be able to talk about what's happening to them, but it's empowering, and it's actually helps some of the symptoms and helps some of the suffering and helps the challenge to just give them the voice to talk about it in whatever way is both kind of developmentally appropriate and feels right for them and their family. I think the reason that a lot of people that work in this work aren't as scared of dying as the general public is because so much of the fear of dying is based around the fear of like what's going to actually happen at that time, and that it's going to be so much harder or more painful or scarier than in reality, it is, and for a well cared for, well managed end of life experience, people are often quite comfortable. People are often not conscious at the end. People are often not in a state of suffering as much as a state of just extreme calm and relaxation. And after you've seen it enough and over, you know that that's actually not the aberration, that's the norm. And the horror stories that do sometimes still happen where somebody doesn't have good pain or symptom management at the end of life or doesn't have an end of life with dignity that they want and deserve, those things do happen, but they're really the more rare experience. They're the exception, and the rule is more that dying is often peaceful and comfortable and can be very well supported. And so I think oftentimes getting to talk about it, part of the way it's empowering for people is it gives them a chance to ask the things that they're most scared of. Like, is it going to feel like, people say, my breathing's always been bad. And I remember going on a ventilator once and it was just so scary to feel like I couldn't breathe. Is that what dying's going to feel like? And you can say, thank you so much for asking that. I imagine that's been really scary for you to think about. And the answer is no. Here's the things we're going to do so that you don't feel air hunger, so that you don't feel like you're suffering. And so, how we care for you at the end of your life so that it doesn't feel hard to breathe and you don't have pain and all these things. It can be such a weight off of people because they've been carrying around these fears of imagined horrors that probably aren't going to happen.
Are there things about kids, right? So I'm a parent. I think, I think you're a parent too, right? You have kids. Are there things that adults underestimate about kids, especially kids that are going, I mean, raising kids, you're always worried about them, trying to do what's best for them. You wonder, are they doing the right things? They don't talk to you as much as you perhaps hope they would. You have questions in your mind. You get to see kids and their families when they're going through something extremely difficult. Is there something that we as parents underestimate about our kids?
Yeah, I think so much. I think one of the things that I've taken away from this work is really just, my son's 8, he's wonderful, and he also doesn't want to talk to me all the time. But I'm always cognizant of, trying, like, I don't want him to feel like he's forced to talk to me, but I want to create space knowing that whatever he has going on in his head and his heart, he can share and it'll be okay. And so not I mean, I think some of the best parenting advice often feels like it really dovetails with palliative care. Like I feel like I often read books on palliative care and think, oh, that's good parenting advice. Or I read parenting books and think, oh, that's what I do with my patients and families. Like, you know, not explaining things away, giving people enough credit for that you let them know that whatever they are worried about or want to share, that you're there to hear it and that you won't minimize it or explain it away, that you won't say, "Oh, don't talk about that. You're gonna be fine." Like, they know they're not fine and they wanna talk about it. We should give them the ability to talk about it. And I think the wise advice I was given from pediatricians and child life colleagues early in my training is that, kids are smart about what they're gonna ask about, and if you modulate the conversation based on the questions they're asking, you'll do it right. That they deserve an answer to any question they ask. It may be like take some thought and practice to make sure you're answering at a developmentally appropriate level, and also asking enough clarifying questions to make sure you're actually answering the question they're asking, which might be very specific and not the more expansive version that you might be planning to answer. So really just clarifying and making sure you know exactly what their question is. But if you do just answering it the same way I think anyone wants with clear and compassionate communication, and kids want and deserve that as much as anyone else. And I think we routinely don't give them enough credit for that.
Are there any questions? I know you said they ask sometimes, is it gonna hurt when they die? Are there other questions that these children ask you that's kind of repetitive? You kind of hear it every now and then.
Yeah, I think "Am I dying?" is a big one, and I think I've answered it not ideally at different points in my career, and I think both yes and no are insufficient answers to that question, and I think a lot of times sometimes the right answer to a question is a clarifying question, and so if a child says, "Am I dying?" I think now one way to respond is, "Wow, that's a really big question. Tell me why you're asking that." And it may be that, their leg really hurts today, and they think that their leg hurting means that they're dying. And then you can tell them that, "No, here's why I think your leg is hurting and you're not dying." It may be, I overheard the doctors talking about that my chemo isn't working anymore, but they haven't told me yet. I'm worried that means I'm dying. And then that's a very different answer. And I think with clarity and compassion, you can respond and say, I'm worried about that too. Yeah. If your chemo isn't working anymore, I do worry it means you're not going to survive this. And then good being open and unafraid to follow whatever questions come next, which might be none and it might be a lot or anywhere in between. And I think always kind of having that same lens as our North Star of like treat kids' questions with the gravity they deserve and the respect and dignity they deserve. Make sure you know what they're asking and why they're asking, and then answer it to the best of your ability in a way that's appropriate for their age and developmental level.
Do you see a like when you're answering these questions, like a child asks you, am I dying? And you're going deeper and deeper and you answer some of their questions. Do you see a change in their emotion, in their countenance, how they look like they feel?
Absolutely. I mean, I think it's like any of us. This is people ask questions they want answers to, and it is even if the answer is hard, it's still unburdening in a way and better than a scary question. It's like thing if you went into work one day and your boss was like, "Hey, I want to talk with you tomorrow about something," and you said, "Am I being fired?" And they said, "Oh, I don't want you to worry about that today. Just wait. We'll talk about that tomorrow." Like that's not at all reassuring. There goes the rest of your day. And I
Yeah.
think we do that to kids all the time. Like they're asking these big hard questions. I think saying, "I don't want you to have to worry about that, honey. Like, don't worry. I'm going to take care of you. You don't have to worry about that." I think does them a disservice. I think the message of "I'm going to take care of you" is a good one and is crucially important. And I think it's part of the answer. But I don't think that message can be heard and felt and appreciated until they get the answer to their question. And if it is, "Am I dying?" I think we owe them the answer to that question and then still following up with, "Yes, and these are all the ways I'm going to take care of you. So do you want to talk about the things we're going to do to help you at this part of your life?" That I think it's not wrong to want to protect children and make sure that they have some shelter. Like that's the role of a parent, that's the role of a doctor. But I think it's a miss if you only do that without giving them the respect and dignity of answering their big questions.
I know you were talking about earlier how sometimes children want to protect their family and perhaps some topics aren't discussed, those children's with the parents or the parents with the children. What what do children ask you, right, when their parents aren't around because they don't want to hurt them or scare them? What do they ask you that they don't ask when their parents are around? I'd be curious what that is. I mean, I would guess that one of them would be, "Am I dying?" Are there other questions that they ask you when family's not around, when they're kind of unhindered in a way?
That's the big one. That's the one that it doesn't come up all the time, but it does like that's what's on people's minds when they're near the end of their life and they want to know and I think if it feels like a safe space to ask, that's the one that they often ask. Um Others are just sort of more kind of more mundane stuff, like for people that have been involved in sort of their conversations about their treatment, they want to know what's happening or they want to know like it feels like things are changing. Why is that? Um, but that's the big one.
It's a big one. Yeah, I can
Yeah.
see that. Yeah.
Sometimes they're just like regular curious kid questions, like stuff about yourself or just depending on the age also. Um, and we'll always I don't want people to feel like the goal of this is to like get the kids alone and talk to them about scary things. This is almost always done in partnership with the parents or saying like, sometimes the parents bring it up and say, I feel like my kid wants to talk about this. I want someone to talk with them about it. And I just don't think it can be me. Or they maybe aren't the initiator. And we may say, can I talk to you about what I'm seeing from your child? It seems like they're holding on to a lot. I wonder, would it be okay if I took some time to try to talk with them alone? Because sometimes all of us feel more comfortable asking some things to people that we're not close to or don't have a relationship with that feel too big and too scary to talk to with our most important people. And oftentimes parents are amenable to that. And then we just go and kind of see where the conversation goes.
I want to move from children to family now, the ones that take care of these children. So every sick child has family or someone taking care of them. Um, when 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 you're introducing yourself to a family and the child, right? How do you introduce yourself when you come into the room? Dr. Rubenstein, go ahead.
Yeah. So really clearly, though, kind of the way I did at the beginning of our conversation, that I say the first two questions are always, I'm Jared Rubenstein. I'm one of the doctors with the palliative care team. Is now an okay time to talk? And if they say no, we find a different time. And if they say yes, my first two questions are always, have you heard of palliative care before? And what has your other medical team told you about our team? Because to me, I want to know where we're starting. And if sometimes it's no to both and it's a blank slate, great. If it's one of the things we had, like sometimes that's what people share, like, oh, I know what, and they share a misconception they have about palliative care, whether it's from their own life or whether it's something they heard from the medical team. And then we start there. But ultimately, I want people to know that my team and our goal is to really be in their corner and see both them and their child as whole people. We want to get to know them and we think of ourselves, as the team that helps the whole child and family unit, that we're not the lung team or the heart team. We're the your child team. And we want to help with the physical suffering, any emotional suffering, any spiritual suffering that comes up. And I tell them that's sort of the big picture and then tell them the specific things that we do we have expertise in pain and symptom management. And so if that has been an issue, we want to help with that. I tell them we want to make sure that whatever happens in the treatment course, that quality of life is thought about and prioritized throughout, whether it's during treatment or off treatment. I tell them that, this a lot of healthcare stuff, people get asked to make impossibly big decisions about things that are really hard to think about, and that it's not black and white. And we want to help them pick not only the thing that's medically right, but the thing that feels right for their family. And the way that we do that is getting to know them as much as possible and getting to know their values and their hopes and fears and priorities, and then kind of combining all that together with what we understand about the medical situation so we can figure out a path forward that is both medically coherent and makes sense for what their values and hopes are. And then I do often name the also we take care of kids at the end of life part, because I've had experiences where if you don't do it, sometimes if people haven't heard of palliative care before, they Google it afterwards. And because of the world we live in and the internet, the first thing that comes up is associated with death. And then they feel like they met the death team who is being cagey and pretending like it wasn't a thing. Or they have already had that experience. And if you don't name it, the visit feels incomplete because you can sort of feel a family waiting for the other shoe to drop. Like, wait, is this the death team? Like, why didn't they talk about that? Like, are they hiding something from us? And so I want to name it just to be fully transparent so that they don't think I'm hiding something. And sometimes families actually really do want to talk about that stuff, and they're holding back questions that they haven't had a safe space to kind of share them with. And in our world where everyone just tries to reassure each other and tells them not to think about that. Some people really are thinking about that and want to talk about that. And I want them to know that our team is a safe space to ask those big, scary questions if that's something on their mind.
I kind of see the palliative care team as the hard discussion team. You know, the team that you can almost ask anything to. Sometimes when someone's in the medical system, everyone, they're trying to cure you. They sometimes beat around the bush, but when the palliative team comes in there, hey, let's have the elephant in the room discussion. And I believe it provides like a relief to the family. It's almost like a little straitjacket has been loosened and you come to a new place.
Yeah, absolutely. And I think for families that want to acknowledge the elephant in the room, we're absolutely the elephant in the room team. And then some families don't, and then so I also don't want them to think we're just the elephant in the room team, and I really like the language from, Catherine Mannix, who I don't know if you know her work, she's a British palliative care doctor and writer and speaker, and it's just fantastic, but she is trying to move us as a sort of a field from the hard conversations to tender conversations, because sometimes they are hard, but they're more than that, like, they're tender, they're important, they're like they get at the heart of things, and for me I don't want people to be scared off from us because they don't want to have hard conversations, because not everyone does, at least at first. I want them to know that we're the team for the tender conversations, or we're the team that's there in their corner to get to know them and sort of be a support or sort of like a companion on the journey as they go through the healthcare system. That's not always the most patient and family friendly and patient and family facing about that. And so I want like there's a bunch of things we can do, and they to me all fall nicely in that bucket of palliative care. And we have the ability to kind of meet people where they're at. And for the elephant in the room people, we want to help them talk about the elephant. For the people that are just really struggling and want to have someone that they can talk to about what their life used to be like and what their child is like and the things that make them happy, we can be that team and make sure that those things don't get lost sight of, and not just talk about them as like an escape, but talk about them because who they are and what a good day looks like and what their values are should be crucially important to the medical care they receive, especially if they're getting to the point where the standard of care and conventional therapies are meeting their limit.
You see a lot of different types of children with different illnesses, right? Um, some with cancer, some with, uh, you know, perhaps cardiac issues, neurologic issues. Some are nonverbal. And I would hope that most of these children have parents, right, that are caring for them for years. What have you noticed about these parents, right? So you're a parent, I'm a parent. Um, Luckily, I haven't had to go through anything like that myself. There's a lot of parents out there, and most of us have never had to go through a it sounds so devastating. It's a huge fear, I think, for most parents. What have you noticed? How do parents behave with their kids? What have you are you in what's your experience with that, with parents of these kids?
Such a good question. It's very much not a one size fits all, and I'm reticent to say like there's sort of a type, because there's a lot of different ways to do anything. There's a lot of different ways to be the parent of a sick or a medically complex child. I think uniformly one is that they all want to do right by their kid, even if sometimes what their version of doing right may bump up against what the medical community thinks is right. There's nobody that brings their kid to healthcare to get bad care and to not be taken care of. And so all of them are loving families. All of them want to do right by their child. And then a lot of times our role is figuring out the specifics of that. Like when the rubber meets the road, what does it look like to take the best care of your child? What does it look like, because of the way you love your child, how can we help you make decisions about that? Because some loving parents make decisions that are always the most life prolonging and the most aggressive medically. And other equally loving parents may make decisions that actually lead to shorter lives for their children, but ones of perceived higher quality or more comfort, or allow them to meet a goal that as a family unit is really important for them. And our goal is really to validate both, that like both those families are equally loving. One's not a fighter and one's a quitter. They're both just good families that are trying to do right by their kid, and making sure that we can help the medical care be right for them. And I think a challenge for a lot of us in healthcare is taking our own values out of it. That like, if I help someone make decisions about their child's healthcare based on my values, I'm doing it wrong. My values are irrelevant to the situation. It's really about getting to know people and their families enough to know what their values are, and then using my medical expertise to kind of tailor the medical recommendations and to tailor the care they get to fit within that paradigm. I think um, the I think a lot of the thing we see from families too is that they don't want people to be afraid of them. I think what we hear a lot is because they're living every parent's worst nightmare, and they are acutely aware of that, and they know what that does to other people. And I think a lot of times they feel people pulling away from them because they either don't know what to say or don't know how to support them, or are worried about doing or saying something wrong. And that's when I was talking earlier about sort of improving just the general societal grief literacy and death literacy. I think a big part of it is that it's that we don't as a society support people in their difficulties in a publicly supportive way. I know there's folks doing work on like creating grief literate communities at work, so that like if people go back to work and you never know what somebody's private challenges are outside of work, but creating infrastructure and a general competence around how to have empathy for someone even if you don't know what's going on, or how to create a safe space for them to talk about what's going on and still support them in the workplace. I think parents want support in ways that make sense and helps for them. And I think one of the sad similarities I've noticed between my home in the States and my new home in Canada is that we are great at mobilizing resources to very specific places, and getting kids to hospitals and getting kids to where they get the care, but then not giving families the same support to be able to care for them at home in a way that fits and it feels right and makes sense. And that there's this significant mobilization of resources to these very specialized places. And then we create scenarios where now children need specialized medical care, whether it's like a feeding pump and a feeding tube or a breathing machine, and then sending kids out into the world with those, and not using the same robust mobilization of resources to give parents the tools to actually care for them effectively at home.
Uh, Now I want to talk about you some. Okay.
Sure.
So after seeing all of this, I imagine you've maybe had some life changes, maybe think of life a little bit differently. What have dying children taught you about life?
Such a good and such a complicated question. I think, on the one hand, I think people have they'll have a near death experience, or they'll hear about something and they'll say like, I'm going to change the rest of my life. I'm going to take advantage of every moment, and I'm not going to have a wasted second. And I think that's great and noble, and I think it's impossible. Like, I know absolutely how precious life is. And sometimes when I'm playing with my kids, I scroll on my phone because I get bored. And I hate that. And I also try to be gentle with myself that, like, yes, I very much know how important things are. And I very much love my children and value time with them. And I can't be 100% present and 100% focused on everything 100% of the time, because that's a tall order. And so For me, I go back and forth, and I think this experience and knowledge is, I think for a lot of us, is sort of both a blessing and a curse. Like, on in one of my previous roles, there were a few of us on the palliative care team that were all about to have a child at the same time. And we talked a lot about how exciting and terrifying it was because we see all the bad things that can happen. And that for talking to friends or family that weren't in the work, it was so hard to be as what felt to us naively excited as they would be because we knew how bad things could be. And so on the one hand, that's really hard. And it does it like I remember, and for our son, our first child, his pregnancy actually was really complicated, and we did have a bunch of challenges, and he spent time in the NICU and a bunch of time in the hospital after that over his first couple of years of life, and it's hard. And so on the one hand, my mind always goes to the worst case scenario because I've seen most of them. And for me, both during our 2 pregnancies and later now with 2 kids in the world, try to reality test with the sort of the mantra that I have is that, like, people only still exist because for all of human history, most people have been fine most of the time with no medical care. That, like, if everyone needed specialized medical care, there wouldn't still be people. And the fact that there are still people means that most of the time everyone's okay. And in my mind, I have sort of those 2 sides at war all the time, but trying to sort of be in the middle of like, today's okay. And there is something nice about going home after a day of dealing with really hard things and going into a house when nothing really hard's happening. And I have a wonderful wife and 2 wonderful kids that are there, and I can just be with them, and I don't have to think about it. And I think having coping skills, like I was talking about earlier, that both like at work that we can help each other kind of process so we can leave some of it on the field. And then for me, like, I really like my commute home from work, that whether I'm listening to music or a audiobook or a podcast or something, that that's that time of like no other stimuli from the world. Like, before I go from a place where there's a lot happening in the hospital to a lot of things happening at home, that it's sort of like a reset and a barrier a little bit, that like that 15 or 20 minutes gives me time to kind of reboot and get ready for my new era of life, or that new sort of zone of things where not bad things aren't happening, and to allow me to be present and leave behind some of the sadness of the day so that I can just be excited to see my kids and happy to be with them and play with them and watch them do the things they want to do. And so I think, and this was a long kind of rambling answer, but I think for a lot of it, it's always being caught between those 2 extremes and trying to kind of walk in the middle, and just, while in no way committing to saying like I'm going to live every second of my life perfectly and make sure that no moment goes wasted, but a much more practical just sense of gratitude that, like, you know what, for right now, nothing bad's happening. And for right now, I'm going to sit and play with my kid doing this thing, or just be with them, or just laugh at how silly they are, because like that's what's most important right now. And not the unrealistic expectation of being perfect all the time, and valuing and honoring every moment, but more just like an ever present kind of undertow of gratitude that, like, no matter what's happening, even when things are hard, there's also things to be grateful for, and trying to kind of live that as much as I can.
Yeah, with my kids, many times, like, we'll pray before we'll say grace, right? And sometimes I'll say thank you for a few more hours alive. If you can work that into a habit, you can maybe appreciate your life in chunks over time. I remember when I would come home from volunteering at hospice, uh, I would appreciate things more. My mom, my sister, my brother. I didn't have kids at that time, but when I want them to get a perspective on things, sometimes I'll share something that's appropriate for them to realize how good they do have it when when they're actual real children that are suffering right now. So,
Yeah,
mm.
absolutely. And I think having that perspective is helpful, and also making sure not to have, like, if everything that my family or kids are upset about gets compared to what I see at work, like, nobody's allowed to have a bad day ever. And being mindful that, like, it's also relative. Like, I remember, I think it was when I was in residency and I had just a really hard day at the hospital, and I went home and I stopped by a fast food place on the way home, and, like, I just spent the last 12 hours sort of managing all these sick and critically ill kids, and I'm carrying the stress of that. And while I'm waiting in line at the fast food place, I see the person at the register looking as stressed as I felt over the last 12 hours, and realizing that, like, it's not a like, it's all relative. Like, everyone's hardest day is their hardest day, everyone's hard experience, and I think it's puts too high a cost, or puts too much of a premium on saying, like, that person also gets to have a really hard day of trying to get everyone their food on time, and that it's not better or worse, or less hard or more, it's just different. And that, like, also being able to say, like, when my son bumps his knee and he's crying because it hurts his knee, I just came home from a kid dying at the hospital. I know it doesn't hurt the same, but in that moment it does to him. Like, that's his moment, and being mindful to not minimize my own or other experiences. Like, I'm allowed to have a bad day also because something's taking too long, and the gravity of it is zero, and it's something that totally doesn't matter. But I think it's also it's unfair to say, well, like, don't, like, on the one hand, yes, this is like a minor thing, and I would love to get to the point where it doesn't bother me, but also not being so hard on myself or my loved ones about being like, you're not allowed to be bothered by this petty thing. Cause, like, sometimes petty things are hard.
What, uh what do you wish parents, right, of these kids did more of? Um, what do you wish they did more of, during this path, during this time?
Honestly, I think the only one, I'm nervous to say, like, it's their journey. I truly can only imagine what it's like to walk that road, having not done it to any of those extremes. And so I think their journey's their journey, and whatever, like, however they decide to spend the time, I want them to feel like they're doing right by themselves and their family. I think the only one I would probably say is allow your kids to ask what they wanna ask about and talk about what they wanna talk about, because I've just seen over and over how the protection comes from such a well-meaning place, and almost uniformly, it makes things harder for everyone than it needs to be. And that this is already so hard, none of it needs to be any harder. And I think creating spaces for letting kids ask and talk about the hard, I think almost always has only benefits.
You see a lot of difficult things at work, right? Um, I think anybody in that situation would have a lot of grief. How do you deal with that grief that you bear?
I think it's kind of a multi-part answer. One is that I think absolutely I see more sadness and grief at work than most people do, but I think I also see more love and beauty at work than most people do. And the gratitude and awareness of that, I think, helps balance the scales a little bit on a personal level. I think also just having things that help me, like, I having time with my family where I can continually remind myself that, like, right now nothing bad or hard is happening here, and it's just good to be with people. I think time outside and nature and exercise are really important to me. I think if I, like, my body's moving, it helps me kind of think through and process things. And then I think too, just trying to integrate like little, I think of them as like little micro wellness things or self-care during the day. Like there's this sense in healthcare, everyone's always talking about like, don't forget self-care, don't forget self-care. And it's like this thing that happens outside of work in like a prescribed 30-minute chunk between the chaos of your work life and the chaos of your home life. And for me, I think self-care should sort of be peppered in throughout. And so finding little things like whether I think a lot of us on palliative care teams get into the ritual of having lunch together a lot of the time because it's a nice break in the day. You need to eat despite what people in medicine might tell you otherwise. They're wrong. Like having a full bladder and an empty stomach doesn't actually make you a better doctor. And I'll go to my grave believing that. And so, like, time to actually, like, really take care of yourself in concrete ways, like eating lunch and going to the bathroom, but having some time to chat and check in with colleagues, sometimes to process the heart of the day, sometimes to talk about something that's easy and silly and not at all related to the day. I think having times throughout your work life and your home life where you can sort of insert little micro wellnesses, I think goes a really long way. And just feeling like life is hard enough that we do all these things that I think make it harder for ourselves and each other. And I think like some things you should brush your teeth, you should eat healthily, you should get enough sleep. Like some things that aren't necessarily joyful or important. But I think also there's stuff that we create these artificial difficulties that I think if we're all sort of more patient and kinder and gentler with each other, I think it helps everyone.
Well, I want to thank you for choosing this profession on behalf of all the parents that are out there. Uh, a biggest One of the biggest fears I think of a parent is their child getting sick and having a terminal illness and having them die before you. Um, Knowing that there are people and teams and doctors like you, and I know you're part of a team, but I'm directing it at you. Uh, Knowing that there's people that deal with these situations day in and day out and are willing and able to help these families manage such a difficult situation. I mean, I see it. I know you talked about the word holy and you guys don't like being called that, and I'm not really saying that that's what it is, but there's something special about people that work in hospice. There's in palliative care, especially with children. They have something and maybe they develop it that is so important that we don't even know we need until we need it. So, thank you for all that you do. I wish you all the best in the future. The way I hear you talk about doing what you're doing, I can tell you're good at it. Um, and getting better, it sounds like. So thank you for being with me today. If someone wants to find out more information about you or about palliative care, is there any place they can go to?
Yeah, well, first, thank you for all the kind words and the support. I really, really appreciate it. And thanks so much for having me on to have this conversation. This is my goal is to really be out and demystifying and talking about this work and how we can better take care of each other because I think it's really important. Folks can find me on a lot of the social media platforms at Dr. J Rubenstein as a handle, and my YouTube channel you can either link to with that handle or just my name, Jared Rubenstein, on YouTube. Also a website, jaredrubensteinmd.com. And then also I would love folks to check out my new workplace. So being part of the Canuck Place Children's Hospice has been like the privilege of my professional life. And I'm so excited to be a couple months in and learning more about it. And that's at canuckplace.org. And I'd love folks to go and check out the incredible work that the team I'm now part of does.
Great. Well, thank you for being with me today, Dr. Rubenstein.
Yeah, thanks so much for having me. I really enjoyed this conversation.